Good afternoon and good evening, doctors, professors. It's Fiona New from Mary Global Marketing Team. So today it is really my honor to hold this meeting, webinars, between China and Kenya. So actually, I totally understand that this is really hard situation in the world. So we fight with COVID-19 still, for a long time. So Mary is not only medical device company, also we would like to build some, clinical or medical or academic platform for the global platform. So today we really would like to introduce the Professor Peng from China at first. So Professor Zhiyong Peng is the director of critical care department in Wuhan, Zhongnan Hospital, Wuhan University. So Professor Peng has tons of experience about how to treat the patient and how to use the ventilations, medicines, and how to protect ourselves, including doctors, nurse in the critical care department. Also, we invited Professor Peng many times to share this experience, because at the beginning of pandemic in China, he fought with COVID-19 in Wuhan for 3 or 4 months, right, Dr. Peng? So yeah, today I welcome Professor Peng. You share that experience for the Kenya. So welcome, Professor Peng.
Hello, good afternoon, friends. It's my great honor to share my experience with you. Actually, I haven't seen any COVID-19 patients for more than 1 year. I couldn't say I have much experience, but I can say I am one of the earliest physicians to see the COVID-19 patients. So right now, I'd like to share my experience about the long-term outcome of my patients. So I just follow up them for almost 1 year. I'm happy to share this data with you. So can you see my slides?
Yeah.
Can you see my slides?
Yeah, Professor. Yeah.
Okay, it's okay for you?
Perfect.
It's okay for you? Okay, my talk is about the dynamic changes of outcome in survivors from critical ill COVID-19 within my year. Updates from Wuhan. I'm a ICU physician as well as medical researcher. I have not any conflict of interest to declare. So this is our early report about the clinical features of the COVID-19 patients. So you can see in the early number of the COVID-19 patients, about 20% of them were critical ill patients and require ICU care. And most of them complicated with the multiple organ failure, especially for the ARDS, acute cardiac injury, shock, acute kidney injury. And most of them require mechanical ventilation. And some of them finally switched to ECMO. So almost 1 year passed. So I really want to know what happened in this critical ill COVID-19 survivors. So we set up this protocol to follow up them from 3 months, 6 months, and 1 year after the ICU discharge. And all the patients from the 4 ICUs in our medical centers, and all of them requiring mechanical ventilation, all requiring vessel pressures. And this is the flow chart. And we have almost 160 patients admitted in the ICU. And finally, 110 discharged from ICU, and 106 finally survived from the hospital. And we follow up them initially from 3 months, 6 months, and then 1 year. So we measure the pulmonary function, including the total lung capacity, vital capacity, residual volume, functional residual capacity, and forced expiratory volume in 1 second, and diffusion capacity of the lung. We also measure the immune function, including the lymphocyte counting, and the T cell subset, and the lymphocyte function assays. And we measure the titers of the antibodies against the COVID-19, including the IgG, IgA, and IgM, and also including the neutralized antibody. And we measure the life quality of those patients, including the health-related quality of life, and the cognitive and the psychological assessment. So we also monitor the other organ functions, including liver, heart, kidney, coagulation functions. So this is the primary result. So finally, around 92 patients enrolled in the study, because some of the around more than 10 patients still stay in the hospital for the rehab, and they couldn't come to the hospital for the pulmonary function test. And we take samples, blood samples from those patients. And this is the lung function test initially from the patient. We compare the intubated and the non-intubated, and we measure the pulmonary function test as the predictive percentage of the volumes, because we don't know the baseline volumes. So you can see the around 80 to 90% predicted volumes compared to the volume. And also this is the measurement about from 3 months, 6 months, and 12. And you can see the with time, all those parameters improved, and some parameter almost back to the normal level, except the diffusion capacity, except the chest CD score, except the residual volume. And also we measured the walking test within 6 minutes using the distance and the predicted percentage of the volume. And you can also can see with time, the distance improved, and the predictive percentage also improved with time, and almost back to the 100% of the predictive volumes within 1 year after the ICU discharge. And also we measured the immune function, including the T cells, B cells, NK cells, and the subset of T cells. And also you can see the B cells still lower compared to the normal population, but the other cells almost back to the normal level, including the CD8, CD4, and NK cells. So this is about the titers of the antibody, including the neutralized antibody, also including the antibody for N protein, antibody for the S protein, antibody for the RBD. And you can see around 12 months, around 1 year, almost in 90% of the survivors, the titers of the antibody are still very, very high, including the neutral antibody. This is the neutralized antibody around 20. Of course, decreased with time, but still maintain high level after 1 year of the ICU discharge. So this is the trend from 6 months to 12 months, or from this is IgA very, very low, IgM very, very low, and IgG also decreased with time, but still keep relative high level after 12 months of the ICU discharge. We also measure the other organ functions, including liver, including kidney, including coagulation, including the glucose level. And also you see this is the cystatin C, because all these patients were very, very thin because of the ICU stay. So we used cystatin C rather than creatinine to represent of the kidney function, because the creatinine level probably were underestimated in these patients. So we use cystatin C to reflect the kidney function. So you can see in 3 months, around the 20% of the patients still with high level of the cystatin C, but with time the decrease. But around 1 year, still around 5% of the patients still with high level of the cystatin C. And also about the dimer, in 3 months, some patients still high, but gradually decreased in 1 year, almost back to the normal level. This is the ABTT also decreased. Fibrinogen also decreased, but still okay. And this is about the glucose level. Its glucose level actually increased with time. Around 3 months, the average, the middle, around 6, and after 12 months, around 10 to 20% of the patients with the high level of the fasting glucose. But we interview this patient, they tell us they have no any history of diabetes. So this is about the cognitive function around these patients from 3 months, 6 months. And you can see the 3 months, still 10% of the patients with the cognitive dysfunction. But after 6 months, only 2% of the patients with the cognitive dysfunction. About the depression level, depression is the 3 months, 20%, 6 months, 40%, and anxiety almost the same. So this patient still have the high level of the anxiety and depression. So after 6 months. So in summary, so most of the survivors were sort of positive for IgG and neutralized the antibody against COVID-19 with high titers after 1 year, although those titers decreased with timing. The most significant changes of the lung function is the decreased diffusion capacity of the lung, expressed as the DLCO. Although gradually improved with that, but still around 20%, around 20% of the impairment compared to the predictive volumes. And the exercise capacity also improved and almost back to the normal life. However, the chest 3 score still have some problem. About the lymphocyte function, the B lymphocyte quite low initially, but gradually improved. So, and also about the liver function, kidney function improved, but some patients still have some high level of the fasting glucose, which is called hypoglycemia. After 6 months, after 1 year, but we don't know why this happened. So we should pay attention to the patients. So in one word, most of the patients recovered well, either with the pulmonary function or with the immune function after 1 year of the ICU discharge. So this is the good news for us. Thank you for your attention. I'm happy to take any questions.
Thank you so much, Professor Feng, for your very valuable experience sharing. So we're going to invite our expert from Kenya to deliver his speech. Please, Professor Feng, to stay us for more times. We will start the Q&A section once after Dr. Isaac deliver his speech. Thank you once again, Professor Feng.
Okay, my pleasure.
Thank you so much. I'd like to invite Dr. Adam Besa Isaac from Kenyatta University Teaching Referral and Research Hospital to deliver his speech about the experience from Kenya. Please, Dr. Isaac.
Thank you so much. My name is Isaac Adembesa. I'm the head of Department of Anesthesia and Critical Care at the Kenyatta University Teaching and Referral Hospital, which is basically a level 6 referral hospital. It is a public hospital. Next slide, please. Kenyatta University Teaching Referral and Research Hospital is a public hospital, 650 beds. We have 8 operating theaters. Right now, due to COVID, we had to increase our ICU capacity. So right now, our ICU beds are 60. Out of these 60, 40 are dedicated to COVID patients, and the other 20 are for non-COVID patients. We also have an oxygen plant. As we've all known, the most important treatment for COVID-19, especially for the patients in ICU, is oxygen. So you must have a reliable source of oxygen. Next slide. Just to give a perspective of the picture from Africa in general, if you can see at this chart, which is from the African CDC, as of the 13th of this month, there were about 4.6 million confirmed cases in Africa with 125,000 deaths. Next slide. For the situation in Kenya, up to now, we've reported about 164,000 confirmed cases. with 2,950 deaths. I know the question on everybody's mind is why are the numbers in Africa low? So next slide, please. Next one. Now, as we all know that Africa is a young continent. 85% of the population in Africa is below the age of 40. And again, as we've learned from this pandemic, majority of the deaths are in the elderly population and people with comorbidities. So this could be one of the reasons why we've not seen higher deaths in Africa compared to the other continents. Next slide. The next thing is a huge percentage of the population in Africa, and here we are talking of 67% of the African population live in the rural areas. Now, again, as we've learned over the last 1 year, the most effective strategy against COVID-19 is wearing a mask and social distancing. In the African rural areas, social distancing is not an issue, unlike in big cities we see in Europe or in the US, where we've seen the numbers, skyrocketing. So this could be the reason why we are seeing low numbers in Africa. The other reason could also just be because of under-testing, because of the limited resources. And also, we have to give credit where it's due. The African governments have been very quick, especially in Kenya, in putting down lockdowns whenever they feel like the numbers are getting out of hand. Next slide. So what is our experience at Kenyatta University Hospital? Next slide. As I had mentioned, we have a 40-bed ICU dedicated to critically ill COVID patients. Our main ICU has negative pressure, and we have designated separate donning and doffing area with clear IPC guideline to the whole team. We just to also increase our monitoring of patients. We have CCTVs installed in the ICUs, plus central monitor, which is in the clean area of the ICU, so that whenever staffs are not inside with the patient, or those staffs which are outside are not attending to the patient, they serve as extra eyes. Next slide. So this is one of the screens from the CCTV. You can see their team inside attending to the patient. We are lucky to offer, the whole actually range of critical care services, and we are able to do both non-invasive and invasive monitoring of these patients. Next slide. Again, ICU is a multidisciplinary unit. So in addition to the various specialities within the doctors and also the nurses, we work closely with the pharmacies, laboratory, biomed, nutrition, psychology department. As we've seen from the presentation of Professor Peng, a lot of these patients have psychological issues after. Sorry, there's a lot of echoes. I don't know whether it's from my side. Hello?
Hi, Dr. Isaac. Your voice is excellent.
Yes. Okay, we can continue. Okay, so next slide, please. Next slide, you can go full screen. Yes, so in terms of how we manage our patients in our ICU, on admission as a standard, all these patients, come with a PCR test, just to confirm the diagnosis of COVID-19. But in the event of emergencies, like those patients who come in as emergency surgical patients, we do rapid antigen tests, just to allow us to know where to place these patients. Then we continue with the operation. Then after that, we get a confirmatory PCR test. We also do all the hematological tests, like a hemogram. We do biochemistry tests like QECs, LFTs, blood gas analysis. Initially, at the beginning of the pandemic, we used to put all our patients on antibiotics. But then along the way, we learned that a lot of these patients don't have superimposed bacterial infection. It's purely a viral infection. So we only consider antibiotics if we have a positive culture result or our procalcitonin or other markers like elevated white cell count. That's when we put the patients on antibiotics. Again, in terms of knowing which patients will do well or not, we've also learned that those patients who have elevated D-dimers and ferritin levels tend to do poorer than those who have lower levels. And then, because COVID-19 is mainly a respiratory disease, it's always good to image the chest. So chest X-ray is standard in our ICU, as well as high-resolution or CT scan for some of the patients. Next slide. Now, in terms of management, again, a lot has changed over the last 1 year. But as a standard, all our patients are on dexamethasone, 6 milligrams once a day for 10 days. And this is based on the results from the UK recovery trial. As of the beginning of early this year, during the third wave, we've also included tocilizumab as part of our protocol for this patient, unless the patient is immunocompromised. From this part of the world, HIV and TB are common. So for those patients who are immunocompromised, we don't give them tocilizumab just for the simple reason that it can reactivate those with latent TB infection. Again, all our patients are on thromboprophylaxis, low molecular weight heparin, or the other anticoagulants if heparin is contraindicated. For now, the biggest question is whether we still need to give the concoction of vitamins. I know at the beginning of the pandemic, we used to put all our patients on vitamin C, zinc, and vitamin D. But again, recent data coming out shows there might not be much benefit from giving this kind of concoctions, although we don't have enough evidence. So some doctors still prescribe, and some have moved on and they don't prescribe at all. Again, you could see from Professor Peng's presentation from the experience in Wuhan, a lot of these patients present with hyperglycemia, and therefore glucose control is very important. So a majority of the patients, in our ICU are on insulin infusions just to keep their glucose control within normal. Remdesivir, we used to give it initially to patients with severe COVID, but again, based on the data that has come out and the recommendations from WHO, we've abandoned that practice. So we no longer put our patients routinely on remdesivir. Ivermectin is still debatable. There isn't much data, but we don't use it again routinely in our ICU. As I had mentioned, we don't start our patients routinely on antibiotics unless there's a superimposed bacterial infection. There is currently an ongoing clinical trial on convalescent plasma. We should be releasing the results very soon. It's something that we've also been considering for some of our patients who meet the inclusion criteria. And then again from the data that has come out, you all know that patients who end up with severe COVID-19, they tend to have comorbids, especially hypertension, diabetes, obesity, and we continue with their medications just to optimize their baseline. Next slide. The other important thing, just like in any ICU admitted patient, is nutrition. So we work closely with our nutritionists to ensure that the nutritional needs of these patients are taken care of. Again, as per protocol, we prefer enteral feeding to parenteral. We only go parenteral if the patient is not absorbing enteral feeds. We have regular physiotherapy, and we call upon our psychologists every now and then to come and talk to our patients because of the stress of being in ICU, as well as the stress of having the disease. The other contentious issue is about the fluid therapy. Nobody really knows how much fluid we need to give these patients. And for us, we've adopted a conservative approach because we know that again, if you give a lot of fluid, this is a respiratory disease with the alveolar membrane affected, and therefore when you give a lot of fluids, you worsen the ventilation perfusion, and therefore worsening oxygenation. So there are various strategies we look at, which include a simple strategy just like passive leg raising, to know, especially for those patients who are intubated, how much fluids we are giving. Quite a significant amount of our patients develop acute kidney injury, and they are on renal replacement therapy as well, which ranges from regular hemodialysis from those patients who are hemodynamically stable to CRRT, those who are hemodynamically unstable, like those who are in a cytokine storm with multiple organ failure. Next slide. As I had mentioned, COVID-19 is a respiratory disease, and most of the patients are admitted in ICU because they are in respiratory failure. And the commonest type of respiratory failure in this patient is what we call a type 1 respiratory failure because of ventilation perfusion mismatch. And therefore, it means most of these patients, the main issue is oxygenation and not ventilation. And based on this, next slide, please. For those who've been following literature closely, this chart is very familiar. Again, I got this from a study published from China. And initially, the recommendation was that for critically ill COVID-19 patients, if their PFO2 FiO2 ratio is less than 150, then you intubate this patient and mechanically ventilate them, of course, using lung protective strategies. And then proning was also recommended. But from our early experience, we noticed that a lot of our intubated patients were not doing well. The mortality was very high. And based on that, we developed a cautious approach for those patients who are fully conscious and cooperative. We start them on NIV, even if their PFI-FiO2 ratio is less than 150, or high flow nasal cannula. And we've seen very good outcomes based on this strategy. So for us, our practices, we start all these patients on NIV or high flow nasal cannula, and only intubate them if they have failed the same. Next slide. Now, this is a paper we published in July last year based on our early experience from our ICU. So we noticed our mortalities were very high with intubated patients. So we opted to try NIV. At that point, there wasn't enough data on NIV, the effect of NIV on these patients. Next slide. And what we found that when you start these patients on NIV, you can see majority of them, by the time they're admitted in ICU, they're already on high flow oxygen via non-debreather mask, and you can see their average PaO2 was around 40, but when you put them on NIV, by the fourth gas, which means almost 24 hours later, their PaO2s had improved to acceptable levels. There wasn't much change in terms of the PaCO2s change when you put these patients on NIV. So it was based on this initial observation study that we adopted the use of NIV as our first line instead of intubating these patients. Next slide. So how does our mortality compare to the rest of the world? So I went looking into literature and came across this systematic review meta-analysis paper, which had looked at various studies that had been carried out in Europe, Asia, and part of North America. Next slide, please. And from this meta-analysis, you can see the average mortality across the ICUs for critically ill patients was ranging somewhere between 34% to as high as 49.7%. So how do we compare to these ICUs elsewhere in the world? Next slide. We had our first admission in our ICU at the beginning of April last year, and we've since had a total of 571 critically ill COVID-19 patients through our ICUs. And out of this 571, we've lost 195, which is a mortality of 36%. So yes, we know we can do better than this, but considering we are a new hospital, I think this is something that we need to build on and get even better outcomes for our patient. Next slide. So some of the challenges we've encountered, as I had mentioned, we are a new hospital. We are slightly over a year old. And because of that, we are still putting a lot of systems and policies in place. And this has quite been a challenge, considering we have to deal with the pandemic as well as put in place various policies. Again, staffing is always a challenge. We started with about 15 beds of ICU, and we've been increasing incrementally as we get staffs along the way. This also comes with its own challenges, because just like in any facility, it takes a bit of time before new staff gel into the system. Stockouts, this is a global pandemic. We get a lot of our pharmaceuticals and non-pharmaceutical from outside Kenya, and at one point, we've been encountering stockouts. Then the other thing is, since we are a purely referral hospital, we receive a lot of referrals from other hospitals, and they've been with these patients for quite some time. So by the time they are sending the patients to us, they are quite sick. Next, finally. So finally, definitely, I would like to acknowledge the support we've received from our management, led by the chairperson and the CEO, who've been our big supporters. And kudos to all the KUTRRH staffs, especially those working in the ICU areas. They've been fantastic. The government has also ensured that we've had a continuous supply of PPEs. We are one of the few hospitals that we've not had challenges with PPEs. Thank you so much.
Thank you so much, Dr. Asok. Thank you for your sharing, and thank you, and especially you and your team, for the contribution to the country of Kenya. So we're going to start our Q&A sessions. Professor Peng, Dr. Asok, I just saw the first question. I think it's the question both of you. So some of our attendees asking what kind of the drug of the choice it is ideally for the management for the COVID positive patient. I think it's a question for both Professor Peng and Dr. Asok. So I'd like to invite Dr. Asok to be the moderator for this Q&A section to pick up the question and also your favorite question. Please, Professor Peng, Dr. Asok.
Thank you so much. Just to start with the first question, what is there, or the best treatment for COVID-19? I would say, as we are all aware, there is no cure for COVID-19. All these therapies are supportive. So everything from dexamethasone, tocilizumab, they are all supportive treatment in the hope that the patient's immune system is able to fight off the virus. Back to you, Professor Peng.
So actually, in my opinion, it's not any specific medications for the SARS-CoV-2. Actually, from all the clinical trials, haven't shown any positive results. But just from the recommendation published from the NIH, published from the WHO, it's just some small recommendation for some specific group of the patients, such as for the based on the severity of the diseases. For example, moderate. If the patient is hospitalized in the hospitalized, but still not so severe, probably you can take some remdesivir to decrease the the instance of becoming worse. So this is some conclusion from the clinical trials. But actually, I haven't used any antiviral medication for the COVID-19. So of course, all the treatments are supportive. So if the patients have become critical ill, probably we need to give some high level of the oxygenation, or probably give some mechanical ventilation. So this is my opinion. So
thank you, Professor Peng.
Yeah, so of course, if the patients becomes critical ill in the ICU, receive the mechanical ventilation, probably we give some corticosteroids to decrease the severity, to improve the oxygenation for the patients. But it's for the corticosteroids, not for the antiviral medications.
Okay, thank you. Babatunde is asking, I'm impressed with the level of care in your Kenyan ICU. Is this a government hospital? Yes, this is a government hospital. And then what is the role of bronchoscopy in your care? I must say we don't have much experience. Personally, I've only participated in 2 bronchoscopies for patients with COVID-19. We didn't find much apart from just inflammation. So I don't have much to comment on that. Maybe Professor Peng, any experience with bronchoscopy for COVID-19?
Bronchoscopy. You mean bronchoscopy for COVID-19, right? So I mean, try to avoid transmission from the patients. So I mean, the protective very important. So if you want to do the bronchoscopy, so be careful for the protective equipment for the for the medical staff. I mean, no any specific indication, no any specific contradiction for the bronchoscopy for the COVID-19. But be careful, try to avoid the contamination, try to avoid the transmission from the patients.
Thank you, Prof. There's another question here. Somebody is asking whether the numbers I've shared are just from Kenyatta University Hospital ICU or from the whole of Kenyan ICU. So these are numbers from only our ICU. We are the biggest COVID-19 ICU in Kenya, and we take a bulk of the patients, especially in Nairobi. Yeah. Next question to Professor Peng. Where is the question? Somebody is asking, my concern is about the ongoing vaccination against COVID-19. What is the efficacy of the vaccine?
So I think they have some publication already for the efficacy of the vaccine against the COVID-19. Around 70% to 90% of the efficacy for the COVID-19. So I highly recommend everybody should be vaccinated from the COVID-19. Try to receive the vaccination. I think the vaccine should be okay for the for the prevention.
Okay. Next question to you, Professor Peng. What's the average percentage of patients, with COVID-19 end up being admitted in ICU and on mechanical ventilation?
So actually, in my units, around more than half of the patients receive the mechanical ventilation in the ICU. Yeah, and some of them switch to the ECMO finally.
Okay. Next question: what ABG findings will prompt a mechanical ventilation in a COVID positive patient?
You mean the efficacy or how it results?
Yes. Maybe you can just talk about the criteria for mechanical ventilation in a COVID.
Criteria. So actually, I don't see any differences of the criteria between the patients with COVID-19 and other and non-COVID-19 patients. So depends the oxygenation level. So if the oxygenation index below 200, so we have detailed the criteria for the mechanical ventilation. So first, below to 300, you just try to the high flow, less oxygenation. If it didn't work, and then try the non-invasive. If it still doesn't work, and then intubated patients. So we have detailed criteria for the patients receive the different level of the mechanical ventilations.
Any experience of the Chinese team as regard transfusion of convalescent plasma from recovered patients to severe COVID-19 patients?
So actually, I haven't used this plasma for the patients. So, but based on the reports, probably it works for the severe patients, but not for the mild patients. But for me, I haven't used this plasma for our patients.
Okay. And then someone has asked me directly, what is the most common cardiac complications of COVID-19? Commonly in our ICU, what we've seen is we see arrhythmias. The commonest arrhythmia is bradycardia. A lot of these patients, you see a patient who seems to be doing very well, oxygenation improving either on NIV or the ones who are mechanically ventilated. Then suddenly they get a bradycardia and they go into systole and they just arrest. That's one. Second thing we've seen for those with very severe involvement of the lung, they end up with right heart failure. So we've seen dilated right ventricles, even if you see it on the CT scan of the chest, or if you do an echocardiogram, we've seen some of these patients with features of pulmonary hypertension with right heart failure. So I can say those are the commons I've seen. Any experience from China, Professor?
So for my patients, around 50%, half of the patients complicated with the cardiac problems, including the arrhythmia, including the active cardiac injury. And some patients, just make suddenly cardiac arrest. So I think it's the mainly due to the hypoxemia, or probably mainly due to the delayed intoxication of the virus to the heart.
Thank you. Another question for you, Professor Peng. If the patient already on lung protective strategy with mechanical ventilation and steady desaturation, meaning SpO2 less than 88% and no ECMO, what do you do after this? What will be your action?
So you can try all the ways, such as the prone position, prone position, such as the paralyzed patients, and so try all the lung protective strategies. So you just mentioned that. So you try the small tidal volume. You try the PEEP. Also, you can use the prone position. You can use the muscular. You can polarize the patients. And so finally, you all doesn't work, probably switch to ECMO. So ECMO is the final rescue way for the patients.
Thank you, Professor Peng. You know, people have been giving reasons of, you know, Africa being a majority of the population being young. That is why the numbers of critically ill patients are not as high as in Europe or America or in Asia. Is asking if there could be any other reason to explain that.
So I don't know, because the very lot is any variation, is any variant type of the virus. I know, you know, the early COVID, the early SARS-CoV-2 virus probably attacked the older patients, but I mean the new version of the SARS-CoV-2 probably.
What is the most useful ventilation strategy in those intubated patients?
We just mentioned that non-protective ventilation. So small tidal volume, PEEP, but the people you cannot set it too high, around probably less than 10 centimeter water. And I mean, prone position ventilation very useful for those patients. Also, finally, you can paralyze these patients for a couple days, and to see how the lung function improve a lot.
Maybe just to add on what Professor Peng has mentioned, the other thing we really pay attention to when we're ventilating these patients, just like any other patient with the ARDS, is what we call the driving pressure. It's very important to keep your driving pressures below 15 centimeters of water.
Yeah, of course.
As well as, yes. So that is very important.
Yeah, of course. Yeah, less than 15. Yeah, try to maintain less than 15 centimeter water. Yeah.
Thank you. Any other question before I revert back to the admin? On the chat box, I've just seen in another question coming. How do you assess or monitor nutritional status of the patient? Professor Peng, any take on that?
I don't think any differences compared to other critical ill patients. So just use the usual way to evaluate the nutrition status. So such as the muscle, such as the everything you can use for the routine ICU patients.
Thank you, Dr. Isaac. I think we only have the last one for both you and Professor Feng. Do you use propofol for sedation or another medicines in your ICUs for COVID-19 patient when you do the ventilation?
Okay, so depends. So if the patient's hemodynamic stable, we can use propofol for sedation. If the patient's complicated with hypotension, complication with the shock, so try to avoid using propofol. You can use the other medications such as the midazolam for the sedation for the patients.
Just to add on to that, in our ICU, we commonly use dexmedetomidine in combination either with midazolam or ketamine if the patient is hemodynamically stable, or sometimes you have to use propofol, especially for those with the neurological symptoms. We've seen quite a number of patients coming in with ischemic strokes as a complication of COVID-19. So it just depends on your hemodynamic state of the patient. The other thing you need to note is when it comes to benzodiazepines and opioids like morphine or remifentanil for sedation, then they also increase your chance of your patient developing ICU delirium. So you have to keep that into consideration as you choose the best sedative to give to your patient. I've seen one more question. What has been the prevalence of delirium in COVID-19 cases in KU. I don't have that data. I think it will be a good thing to collect that data. We've seen quite a number of our patients developing ICU delirium, but I can't put a figure onto that. But I think it's something we need to study and document. Yeah. Oh, okay. There's one more question which has come in, and this is to Prof. Peng. Do you use traditional Chinese medicine? It's called Liang Huo for COVID-19.
Maybe I think it's useful for the mild case. And useful probably for the moderate case, but we never use the Chinese herbs in the critical ill patients in ICU because we cannot feed the herbs for the patients. But based on the report, the Chinese medicine probably will decrease the instance of the severity of the patients. Probably will prevent the patients transition from moderate to severe or from the mild to moderate. So this is the from all colleague report using the Chinese medications, Chinese herbs.
There is an interesting question here from Friday Okadu. Do you think this pandemic will ever come to an end? I think the only way out of this is vaccination. I don't see the other way around. Hopefully, but with the global challenges of access to the vaccines, especially for us on the African continent, I don't know how long it's going to take before we have a critical mass of the population vaccinated.
So I just missed this question. You want to ask me?
Someone was asking, do you think this pandemic will ever come to an end?
I have confidence, but we need time because this is the global issue. So we need to collaborate together, and so if they have any new cases in any countries, we can say this war will end. So this is very important for us to work together.
Okay, thank you so much. Thank you, Dr. Asak. Thank you, Professor Peng. It's a very great honor to have this excellent experience sharing and also a contribution from Professor Feng and Dr. Asak. Let's thank both of the experts once again. And also on behalf of Mindry, we want to thank for all the attendees today from the different regions and countries. We have almost around 100 attendees come from East and West Africa, and some of the colleagues, some of the guests also from Middle East, from Africa. So please take care during this pandemic. I like to wish to see you very soon in the near future. Thank you once again, Professor Feng, Dr. Asak. Take care.
Thank you so much.
Thank you. Take care.
Bye-bye.
Take care. Bye-bye.